So now we'd like to get our roundtable discussion going, and so I'd like to ask the participants to please come on up to the stage and take your places. We are ready to begin our panel discussion. I do want to let you know who is on our panel. Of course, you've already met two of them. The Honourable Terry Lake, the Minister of Health for British Columbia. Thank you for being with us. And as well, Dr. Luis Lourez, as you know, Executive Director of UN AIDS. He's also on our panel. And joining us as well, the Honourable Dr. Clarice Modeste Kerwin, the Minister of Health for Grenada, well known in her home in Grenada as the Doc. Dr. Modeste Kerwin's accomplishments as Health Minister include construction of the new Grenada General Hospital, implementation of the HIV/AIDS World Bank project, establishment of a cardiology program, as well as increased access to rural health service. Welcome, Dr. Modeste Kerwin. I also would like to welcome Dr. Christine Nibiru from the AIDS Support Organization in Uganda, known as TASO. As a public health specialist, Dr. Nibiru participated in the development of the Uganda National Antiretroviral Therapy Policy and Treatment Guidelines. She was also on the team that developed the 2007-2011 Uganda National HIV Strategic Plan. And she has served numerous positions with TASO and currently as the Deputy Executive Director of Programs and Strategic Information. Welcome, Dr. Nibiru. Also joining us on the panel today, Nikos Dedes from Positive Voice. Mr. Dedes is a founding member and president of Positive Voice, the Association of People Living with HIV in Greece. He is also a founder and vice chair of Prometheus, the Hellenic Liver Patient Association. He is a former president of the European AIDS Treatment Group, and he is currently on the board of the European Medicines Agency. Welcome, Mr. Dedes. And as well, finally, well known to all of us, Dr. Julio Montaner, Director of the British Columbia Centre for Excellence in HIV/AIDS. Dr. Montaner is the chair of AIDS Research and heads the Division of AIDS in the Faculty of Medicine at the University of British Columbia. He is also the past president of the International AIDS Society. And so I would like to now ask each of our new panelists, the people who have just joined us, to please give us an opening statement. So we will start with Dr. Modeste Kerwin.
Thank you. Thank you, Madam Moderator, and a pleasant good afternoon to my colleagues here at the head table and to all of you. Really, when I got the invitation, I was really excited because there are a number of challenges that we are addressing or seeking to address in Grenada, and I thought this would be the right catalyst for us. I want to commend and congratulate the District of Columbia and especially the City of Vancouver for leading the charge in embodying the concept of treatment as prevention. And what I have to take back at home will make significant difference because someone else has been and done what we need to do, and therefore that example will be a powerful tool for us. I am pleased to be here, and I look forward to sharing with my colleagues whatever information can be generated around this discussion. Thank you.
Okay. All right. Thank you. Okay. All right. Thank you. Thank you. I don't know. I don't have a mic here. Thank you. Thank you very much. Okay. Let's now hear from Dr. Nibiru, please. Your opening remarks.
Thank you very much. I'm very happy to be here. And I want to thank the organizers and the keynote address that we have just had, and the direction that we are getting in terms of where we should be looking in setting the bold new targets as we move forward. And of course, as we have heard with the new guidelines from WHO, the higher CD4 count and the efforts that are ongoing, whether it's seek and treat, like we have heard from Vancouver, or test and treat, like we have heard from elsewhere in the world. I think the issue has been set forward that we will need to actually make sure that the bottlenecks to ensuring that retention, adherence, and making sure that the gains that we get from the expansion and scale-up of the treatment actually translate into treatment as prevention. I was very excited to hear about the fact that UNAIDS is leading and guiding about strengthening the community systems, strengthening, because that will be one of the ways, a very important pillar in ensuring that what we are doing as we set out to scale up is actually maintained in a sustainable way. And also to hear that we should put the money there, not only talk about communities without making sure that the money follows what we are talking about. So amongst other things that we will be talking about, I'm happy that the concept that is the backbone of the AIDS support organization for the last 27 years, the community system strengthening that has helped us be able to take forward programming as an indigenous organization and contributing to the national and global discourse is getting back onto the agenda. Thank you.
Okay, thank you, Dr. Nabiro from Uganda. And now I'd like to ask Nikos Deres from Positive Voice for your opening comments.
Thank you. Well, I have to admit that the brevity of the Honourable Minister and my colleague puts more pressure to be as fast as possible. But I would like to say that Dr. Loures has covered so many of the comments, of the points that I wanted to raise, almost on behalf of the community. One thing that is perhaps a little bit what we should be able to achieve is how you can operationalize all of these, the manifesto that you have delivered to us today. I think the HIV is an amazing success story over the past 30-something years. We found the virus, we had a treatment revolution, we had new dedicated programs, both a horizontal program at the United Nations and indeed new funding mechanisms like PEPFAR and the Global Fund. And of course, huge investment in research from the National Institute of Health. But as Dr. Loures said, this in large was the result of community mobilization and advocacy and activism, to be more exact, before we turn to advocacy. And it is only that that led to subsequent leadership from scientists and politicians. But there is also a puzzling paradox. With all these instruments and with all this huge success, we still are failing globally to control the HIV epidemic, not least in the region where I come from in Europe, where I don't think there is any one country which has managed to actually have smaller number of new cases. And certainly there is no country in the world which has managed to have a smaller number of infections than people put on treatment. So we do not have this inflection point that we are looking for. And I think that all attempts to prevent HIV transmission independently and before treatment was introduced have actually failed. And I'm not sure I agree with the way that Mark Dybul said that the target for treatment for prevention is something different than the target for treatment as care. I think once we have achieved the target for treatment as care, we will have reaped the dividends and the benefits that this adds to prevention. And I will finish by saying that in order to achieve this, it is important to ensure community acceptability of both the new WHO guidelines and indeed this new concept which has been adopted in some countries, the test and treat. And I want to congratulate the Minister for the amazing leadership of this region in Canada. But as you understand, the major obstacle, and again, Dr. Loures highlighted this to death, is that stigma, the discrimination, and the criminalization that we face around the world is sufficient barrier to not be able to achieve our targets. It is interesting that even in the European Union, the Commissioner on Health, Tonio Borg, had organized a health meeting, and the problem for Europe was considered to be stigma and discrimination, even in Europe. So with this, I think that it is clear that I think that UNH also, and this is a comment that I also made to the Commissioner, it's not sufficient to simply say which are the good policies. I think we have to start castigating the countries which do not adopt those policies, and that includes Uganda, for example, for what we have seen in criminalization, or indeed Russia for the way that they treat substitution treatment and drug users. So I think that we really have to become a little bit more clear of why countries are failing to control HIV epidemic. Thank you.
Thank you very much. Thank you. Okay, and finally, last but not least, Dr. Julio Montana, we'd like to get your opening comments.
It's difficult to come up with anything new and stimulating after the extensive discussions that we had both by my minister, Minister Lake, and by Luis. From my perspective, I think that we are at a critical time where finally there is a voice of consensus emerging, that the science is here, that demonstrates that treatment indeed is highly effective in stopping HIV transmission in all circumstances. And our own data has been very compelling with regards, for example, to injection drug users, a community that was very badly affected, as Stephanie indicated in her opening remarks, in Vancouver and in British Columbia, and where today new HIV infections are extremely rare. But quite critically, as Minister Lake indicated, this is not just because we have treatment available for this community, but it's rather because we have treatment available in the context of very comprehensive harm reduction policies, which unfortunately are being castigated, to pick up on Nico's theme, by the federal government, who is driving my minister crazy, because they want to curtail the harm reduction programs that we have available in British Columbia. And again, thanks to the progressive views of our provincial government, we have been able to protect those programs. And so the point that I'm making is that it doesn't really matter where the science is at, if we don't have a very close collaboration between the policymakers, the implementers, and the science, we're not going to be able to derive the impact that we need to derive. I wanted to take this opportunity to address one lingering concern that has been something that I've been worried about or challenged about in the past with regards to the treatment and prevention story, and that's whether or not treatment and prevention truly works in every setting. We have very good data for vertical transmission, and we have very good data for injection drug users, and there has been this lingering concern about whether or not treatment and prevention is equally highly effective in MSM, men who have sex with men. I was really gratified when the preliminary results of the partner study were presented at CROI a couple of weeks ago, maybe a month ago now, I forget. But to make a long story short, having followed very carefully a large number, close to 1,000, heterosexual and homosexual couples, they were able to present their preliminary results whereby there were no instances of HIV transmission for as long as the index member of the couple in the homosexual couples had a viral load below 200 copies per ml. and actually the degree of protection that they were able to identify was of the same order of magnitude in the heterosexual couples as it was in the homosexual couples. And of course, the study continues, so the 0% risk estimate has a confidence interval that goes all the way to up to 4%, indicating that with continued follow-up, that confidence interval is going to continue to shrink. But it gives us a great deal of confidence that if we continue to ramp up treatment prevention strategies in the homosexual community, we will get to a point where we get the herd immunity that is necessary to see the impact of the strategy in what until now has been one of the most difficult areas to actually duplicate that effect. So my comment, if you want, relates to the fact that the data is seen, the data is extremely consistent in every single most affected group that we have looked at. The level of protection that we're getting is highly consistent, nearly complete. There is no excuse for us not to move. And on that note, I second Nico's proposal. If we remove the stigma and discrimination and we bring the service to the people, follow Luis's command, we will see the beginning of the end of this epidemic.
Okay. Thank you, Dr. Montana. Dr. Lourdes, would you like to reflect on what you've heard so far from the panelists' opening statements?
I agree with all the panelists. I had my share.
Okay, just thought I would give you the chance. But anyone who would like to jump in at any time, we're welcoming any thoughts you have. Just barge right in. We want this to be a lively discussion. So let's just start with the first question, and I guess it's for Dr. Lourdes. Is the science robust enough to fully embrace the just released WHO guidelines?
Yes, I think if you understood your question, I think this is to me is the bottom line, is the reference point to go. And as I comment, I think WHO is respond to science. I think the guideline is robust, the guideline is well-rooted. I think there is we are seeing open in terms of moving, bringing the developers that they happen. And definitely, yes. I think the question, the fundamental point for me is the shift is towards implementation. That's where actually the focus should be. We need to avoid the risk that sometimes the scientific community is getting. It's like a trap. You start recycling the debate instead of trying to find a way out and a way forward. But maybe that's more left to the policymakers to make this differentiation and to really to try to bring the focus to implementation. I think science is clear. What has a tail, has ears, looks like, and make the same noise as a cat, very likely is a cat. You know, when it concerns reality, let's move forward. What I'm trying to say, I think Rudy is right. All the indications are to go for early treatment and to offer treatment to larger populations of people infected by HIV/AIDS. This is, I think, where things should go.
Would anyone like to also speak on that? Dr. Modeste.
Yes, thank you. I just, perhaps I did get a little, how shall I, technology shy a little bit because I lost my page in the beginning. But it's interesting, the question you ask, is the science robust enough? And I think it is. If we look at the example that Vancouver set, there's a lot of data there, a lot of success stories that could guide us. But I think what we're doing here perhaps is, undoubtedly one of the more important things that we need to do, which is bringing together the technical knowledge that persons bring here today and bringing the politicians together. And perhaps there needs to be more of that, because oftentimes we find the technically minded people, the researchers, meet by themselves. And then politicians meet by themselves. And therefore, it takes a long while before the information that has been gathered and the recommendations reach the politicians. And then it takes perhaps even longer for their recommendations to be translated into actions. And I think we can save time by bringing both together so that politicians can be informed and they can make decisions based on those information. So I really want to commend and applaud what is happening here today. And I wish we can do more of that so that in terms of translation of recommendations, times will be shortened. I heard today that sometimes between the data gathering and the recommendations and implementation, it could take up to 14 years. People are sick, people are dying. We do not have 14 years. So I think we have to find mechanisms like this, where we can learn. Tomorrow, God's willing, I'll be going to one of the institutions, and I'll be able to see firsthand what achievements, milestones have been achieved, and therefore I can take that back home and say, it can be done. I wanted to just...
Well, how else can we shorten that time? I mean, yes, we can have conferences like this, but what else can we do? As you say, people are dying. How do we turn this into action?
Well, Pamela, if I could just speak to that a little bit. I think politicians need to follow the evidence and not ideology. And too often politicians tend to fall back to their ideology instead of looking at evidence and following, you know, where that leads. And one thing politicians love to do is to save money. So if you put all the ideology aside and you look at the evidence and you say, well, you're spending $15,000 per person to treat people in British Columbia through the Treatment as Prevention program. But of course, we're making their lives better, we're making their families' lives better, we're decreasing the transmission of AIDS and making those other families' lives better because they're not getting AIDS or HIV. But we're saving all that money because these people aren't ending up in the acute care system. They're not costing thousands and thousands of dollars each and every day. And the tragedy, of course, is something that's incalculable. But just looking at what it means to having a sustainable healthcare system. So if you put all the ideology aside, look at the evidence, look at the economics, the decisions really follow from that. So I think in British Columbia we've been very good at doing that, I would say. We've had excellent people guide us to those decisions, but it just makes sense. And when you put all that other stuff aside, it just is the right thing to do.
But isn't it often difficult to convince politicians to spend the money up front and think long term and try to get people on side because this will be better later?
It's always difficult. I could tell you how many times people come into our office and say, if you just do this, if you just put some money into this, you will save all this money down the road. So we hear those arguments a lot. But if the evidence is there, and if you are able to make an investment and have proper data and proper accountability, transparency, that gives you the good information to show that it is a good investment, then you want to invest more. So, you know, I think politicians are willing to take that first step, provided they can see the evidence that it's the right thing to do. And on this file, we certainly have that evidence, and it's been easy to make those decisions. But it does need good data and good science to back it up.
If I could add just a little bit of trivia, I think that we need to take advantage of the fact that treatment as prevention is immediately successful. At the moment that you engage a person infected with HIV on treatment, there are quality of life issues and morbidity and mortality issues that you're addressing. You're also preventing transmission, and there are a number of multipliers. So our approach, when I think back, because we didn't plan it this way, many of the things that worked for us was because we did what we did because it seemed to be the right thing to do at the time based on the evidence that we have available. But the lesson that I learned is that treatment prevention, because you can see the impact so quickly, is actually addictive. It's addictive to the people, it's addictive to the profession, it's addictive to the politicians. We see some and we get more and we want more, and because you realize very quickly that there is more benefit coming to you. So back in the day when we started all of these, because of financial crisis considerations and the like, we could only do a pilot. And we had to say, well, if that's all we could do, we just do the pilot. And so my advice to my colleagues that are having these discussions today is take whatever you can to get started, because the moment you get started, particularly if you use, as Luis was indicating, the hotspots approach, and you go after those hotspots first, then the return on the investment, it becomes so clear that it becomes a very easy argument to make to take it to the next level. So it doesn't matter where we start. At the end of the day, we know where we're going. Just get started.
In
Dr.
my part
Navarro,
of the world, what I've seen has happened has been the realization of the differences in the way that people look at things. The way the scientists will interpret and put forward the information is very different, has been said, from the way the politicians will be looking at things. And that space takes time. And originally the thinking was the scientists develop the science and then pass it on. And I've seen a transition and a transformation towards let's do this, and right from the beginning have the politicians and the scientists go through this process and have that engagement right from the point of design and implementation of the research, so that at the point when the science is coming out, that engagement already happened. So there are processes that are happening to make sure that that period of time is shortened, and there are also fora that are bringing together the scientists and the politicians a bit more, and the language in terms of when the science is out, what does the politician want to hear, and how will it be presented in a way that will be able to take on the implementation.
I saw you scribbling
I just
furiously.
wanted to share the Caribbean experience, but I can...
No, we'd like to hear that.
I just wanted to share experience, and we are at the point where I feel like it's almost deja vu, because we need to have a paradigm shift in how we look at HIV and AIDS. And when I first became Minister for Health, that was in 1999, we were at the point where we were deciding, could we treat our citizens for HIV and AIDS? Is it financially viable, sustainable? And we weren't sure. And we had some technical experts, those who had expertise in health, those who had expertise in financing, and they demonstrated to us how it actually was an investment to take a loan from the World Bank to treat our people, because our children were dying, young people in their 20s, in the prime of their lives, the productive lives, were dying. And the question then became not whether we could afford to treat, but whether we could afford not to treat. And we were helped by a global effort, because it wasn't just Grenada, it wasn't just the Caribbean, but the Caribbean came together. That was the beginning of PANCAP. And PANCAP rallied other technical expertise from the region as well as around the world. And they were the ones who came and did presentations to our cabinets. And we realized that the time had to be shortened. And it was. So we have become a little bit complacent, and so that gap between recommendation and implementation has widened again. But we have gotten to a point where we need to shift. We need to change our treatment regime. It's not just treating a few, maybe with a viral load of 350 or whatever, but looking to give universal treatment as early as possible. And I believe if the right message is sent by the competent people, that the politicians will listen.
And Nikos, you had something to say.
Well, I think that obviously in the beginning the imperative was the right to life and the right to health, and this is what obviously organizations like UNAIDS put forward. But what I think they can do today is actually make the economic argument, I think together with the World Bank and perhaps the Global Fund and PEPFAR who may have data to demonstrate what is the benefit, and indeed use the examples of the countries which are doing this: Brazil, China, France, British Columbia. And I think peers are better in convincing politicians, or equally good. So I think a combination of a technical presentation from the World Bank with UNAIDS and other good examples could perhaps persuade politicians to follow the example.
Okay, well, another question for Dr. Loures. Are British Columbia, France, the US, Brazil, the Netherlands, Australia, etc., are they right, based on the science, to move to test and treat?
I think they are. There is no question. Taking another Argentinian like Julio, who I am to judge? You know, if Brazil, the Netherlands, is more and more countries, Fabio Mesquita is here, the director, H chief in Brazil. Come on, the knowledge today. Vancouver has a lot of knowledge here. We know that. We are pleased. But the knowledge has shifted already. He's in countries. After 30 years of epidemic, these countries, they know more. Not only in terms of how to judge science, but what's better to their own people. If they decide to move, and when you start to accumulate, it's not one, not two, it's 3, 5, 6 more countries that care a lot about the evidence. It's British Columbia. And there is a clear trend outside there that by itself shows that this is the direction to follow.
And panel, if I could just add to that, I'm not an expert in this field, but from material I read, in British Columbia, if we're going out there and generalizing our testing program, if you find one person out of 1,000 through that kind of a testing system, then you are getting a return on investment in terms of the costs. And when we did that, I think, Julio, it was 6 out of 1,000 that we were finding. So clearly, it's the right thing to do from a return on investment point of view. And obviously, then those 6 people are put on prevention, and all of the things that accrue from that are very positive. So I think the data is clear that test and treat is the right thing to do for many, many reasons.
I wanted to, first take the opportunity to congratulate the WHO for the new guidelines, because it doesn't matter where we are going, we would not be able to globally move in that direction if it wasn't by the huge effort that went into getting the guidelines to the 2013 guidelines. And we could spend a lot of time arguing whether I would have liked it to be slightly different and had another criteria or whatever, but it doesn't really matter. The new guidelines have dramatically changed the landscape, so that even if that's as far as we're going to be able to go today, just doing that would be terrific. Meg Dirty published recently a paper estimating the millions of AIDS cases that would be averted, the mortality that would be averted, the millions of infections, and it's tremendous. It doesn't matter where you look at it. The 2013 guidelines can radically change everything. Now, as we think forward, the problem is that the guidelines have become slaves of the evidence, to the point that we're asking for the ultimate piece of evidence to make every single decision. And sooner or later, I think that a practical mind has to say, we just need to move on. We're making it actually more complicated to screen individuals that are identified as HIV candidates, or people who we want to test, because we need to test them. We need to do the CD4s, and we need to do the laboratories. And I was talking to Joop Lange, who just came from a site visit in Africa, an area that they're planning to do a test and treat study, and he was telling me the nightmare that doing all of that and achieving all of that meant for him and the group. And at the end of the day, when we look at what really is happening on the field, is that people are getting tested late. People are arriving to the clinics with an age diagnosis. People are, and the few and far apart that we identified who had CD4 criteria that were significantly higher than what the current guidelines recommend for initiation of treatment, we're discouraging them from engaging with the system. At the end of the day, those people are deferring treatment technically for a matter of months or a few years, which when we realize that the overall therapeutic exposure of these individuals is going to be measured in the order of 5 to 6 decades, it really doesn't, we're not saving anything. And what we're doing is creating a more complicated system, discouraging people to come forward and not being efficient the way we do things. Mark Dyball said it very clearly in his statement, and I just to translate, he said we need to do more with the amount of money that we have. So the message is clear, we need to be more efficient. Well, if we're going to be more efficient, the only way to get there today, from a guidelines perspective, is to simplify what we're doing. And test and treat certainly delivers that promise. And given the simplicity, the efficacy, and the safety of the treatment that we have available, there is no excuse just not to move.
Would anyone else like to comment on that? Yeah. What is it going to take to move to full test and treat everywhere, not just in the countries and places I've mentioned already? What will that take?
The word was mentioned many times, the implementation, which is the missing link. And again, Dr. Loures paid tribute to the community, both in the historical achievements in the early phases, but also in scaling up treatment, in the task shifting. But you also said that the community is the only way to change the business. You also mentioned the word innovation. I think that we have to revisit this partnership between health systems and community delivery. And I think that this may, and perhaps Julio and the Minister can correct me, I think that this might be more important in developing countries than in countries in the West where the system can operate. Still, I know very much what the importance and the contribution of civil society and patient groups is, but I think it's the key for developing countries. Perhaps my colleague can follow up on that, and Julio, you can say how much this is dependent or is part of the collaboration with the community, but I'm certain that it is imperative for Africa.
Yeah. It has been mentioned earlier about the health systems and how the health systems, if they're not ready and they've already reached capacity, then we are going to be challenged further when we are scaling up. And it's also true that one of the opportunities that we have is the community systems, and those community systems can actually be galvanized now to take on a bit more than they have been doing in the past. And like I mentioned, that the fact is many times the community systems are there, but there's been lip service about how much they can be facilitated, and the money is not trickling down to support the systems to be strengthened. So there is a huge opportunity now, as we are talking scale up, to use that for health systems strengthening and move it lower down to the communities to ensure that the linkages between the community and the facilities is actually facilitated by people that can do work that takes the services right down to the last mile, to the household, to the individual that needs these services. And talking about this is the fact that we have had models like peers with each of the programs, if it's EMTCT, Mentor Mothers, if it's to do with the commercial sex workers, key populations, who are the peers that can help us take this message, and how have we equipped them and built the capacity and networks that will help put this information out there, because literacy, mobilization of communities to come in and get the services, confidence building between the service providers and the communities to come and seek the services will require that people that have been trained within those communities have the confidence and a relationship of engagement has been built so that communities feel that they can come and get the services. And alongside that, for adherence and retention, to make sure that they have information out there as we scale up and as we seek and treat and as we test and treat. The dynamics have changed. You're no longer getting people who are on their deathbeds. You're no longer getting people who are very sick. So that motivation has changed now to a situation where people need to be shown that this is the science and this is why, even when you're feeling well and you're not yet feeling that it is necessary for you to get onto treatment, you do need to get onto treatment for the greater good in terms of prevention. And that kind of message has to go on and has to be passed on with word of mouth through the communication channels that people understand right down in the communities. And I do agree with you that in the Western world, that may not be an issue, but definitely in the developing countries, that is a strength that we must work on, and it's an opportunity that we must pick on and utilize now and strengthen those communities and equip and finance the community initiatives. You want to add something?
You know me. You know, to Nico's point, I think that the role of community on getting us where we got has been crucial. But building on the point that you make, the pressure in the community has been addressed because the morbidity-mortality issue is being addressed for the most part. Not completely, but being addressed for the most part. And so I have said before, it would be very helpful if we could have a louder outcry on the part of community regarding the number of infections that today go unchecked because we haven't been able to extend treatment prevention the way we should. And I wanted to bring up another issue that, builds on the concern of stigma and discrimination. And by no means I want to oversimplify stigma and discrimination because it's a very complex issue and there are multiple determinants and there is no way we can fix it with one magic bullet. But in conversations I had with Nikos over the years, he has actually taught me how destigmatizing treatment prevention can be and how it can help to normalize a person's life. But given the fact that at the essence of stigma and discrimination, there is a component, one of the many components, is fear and ignorance. Treatment prevention can actually be very useful in revisiting that by normalizing the life of people infected with HIV and hopefully through appropriate education, convincing people that we are addressing the issue of effectiveness, etc. Now, having said that, we have failed to properly educate the Supreme Court of Canada, and so we have a mess in our hands in my own country. So I don't want to oversimplify the issue or pretend that it's easy, but I think that if appropriately communicated, this can actually greatly contribute to a better understanding and de-stigmatization, at least in certain regards.
Yes, I just wanted to add another dimension to what would it take to scale up. And I agree wholeheartedly with the approach as to how we deliver healthcare in our communities and de-institutionalizing the treatment from a building out into the community, taking it to the people. But I also wanted to speak on another issue, which again, which is the financing. I don't want it to be, how shall I say, a deterrent, but it is a factor. So, for example, in order to scale up your treatment, you must do testing, and testing cost. Over the years, we in the Caribbean, and I'm sure a number of other countries have had support from Global Fund, from PEPFAR, other organizations financially, and those agreements are fast coming to a halt, and come 2015, we would have to look at how we finance, and therefore, governments would have to look at how they distribute what we call the consolidated fund, the national funds, to divert some funding towards HIV and AIDS and perhaps healthcare in general, because I want to link HIV and AIDS with this whole, the primary health care and the public health issue. Because if we keep singling out HIV and AIDS, we would not get the full benefit of what treatment and our whole approach to HIV and AIDS can do for a generalized approach towards healthcare. Because we have learned a lot from how we have treated AIDS and how it has impacted on us in terms of what is doable and what is not doable. And so I think we are more open-minded as to be more daring as to what we can achieve as developing countries in terms of healthcare. But these institutions and certain governments have assisted various countries in addressing the whole issue of HIV and AIDS. And as the time runs out, it begs the question, will they continue? And if they do not, what will happen to our plans to upscale? And therefore, I wanted to put this on the table. I do not know all the participants here, but I want to raise it as an issue whereby that is given consideration. I do not think we are out of the woods yet, and if the helping hand that we have had over the years is suddenly taken away, that could certainly impact negatively on our ability to treat HIV and AIDS and to follow the example of treatment as prevention.
Well, that's certainly a very, very big issue for everyone. How do we pay for this going forward? Maybe we can start with you, Nikos, because you're from Greece and you know your country has suffered a lot of economic setback in the last while. I mean, how can your country pay for test and treat?
Well, I think that actually the crisis in Europe and certainly in the northern European countries make it an imperative to no longer do business as usual and no longer continue spending money as if they're going to be around. So I think the economic argument that the minister has put forward before, alongside the, I don't remember, the uncountable importance of quality of life and life itself. But I think that exactly because we have the economic crisis, it is important to demonstrate the benefit of earlier diagnosis and earlier access to treatment. I think it's also important to mention at this point that while discussing with a colleague who could not make it, Ken Lisikvese, he mentioned to me on the global scale now to see this idea put forward by the Global Fund for two-year pricing, and I understand there is a consultation which is still not out, and there are concerns of how this could impact the negotiating power of the medicines patent pool or other attempts to lower the prices globally.
Dr. Lourdes.
Yeah, I think during the 3 decades behind us, of course, we have accumulated knowledge in several areas, and one of them was in doing more with less, where we can. And there are a series of efficiency gains that we can factor now to move forward with the AIDS response. Just to give you some examples, starting with how you allocate money. We have clear evidence today in Asia and in Latin America mainly that money has been allocated historically in the wrong ways. They have epidemics that are predominant, for instance, among men that have sex with men, and 0.2% of the money in some of these countries go to programs or MSM. Basically, most of the money is wasted where the epidemic is not. You know, and this is, if you allocate better, if you set your priorities according to your evidence, you do less, you do more with the same money, or even less. You start with this, and in the case of treatment, The same assumption is valid depending on how you implement. And there are a series of other gains that are, for instance, directly related to incorporate of new technologies, of diagnosing point of care, that instead of leaving behind the techniques that are difficult, expensive, difficult to maintain, like CD4 counts, for instance. I think we are probably in the eve of a moment that we are leaving CD4 counts behind, what may be a result also in have some gains in terms of doing more with less or with the same money. To give an idea of magnitude, or estimate, the UNAIDS estimate, for us to retarget according to the WHO new guidelines, that would cost nothing more than 10 to 15% of the money that we have today. And we are speaking here almost in doubling the numbers of people on the treatment because of the efficiency gains that we have learned to do as we move forward. All of that is incorporating. We have 25 countries today, Nico, that has developed already what we call investment frameworks to move the AIDS response forward. In each one of these countries, the analysis has been done in where you could save money and what are the end results if we invest the money in the right direction. Our colleagues of the World Bank are here. I'm sure I saw David Wilson today, and I'm sure you'll have the opportunity during this conference to expand much more on this issue, but it's a reality. We know how to do more using less money today. We accumulate 30 years of experience behind.
Dr. Navarro, is it realistic? Would there be enough money in your country if you had to double the number of people treated?
The case of the investment case has been presented, and those efforts are ongoing, but I think that it is going to take a process. It's definitely the answer to your question is that it would be an unrealistic and ambitious statement from me if I said that we have developed the investment case in Uganda, and based on that, we believe that with the efforts that are ongoing to see our countries in the developing world getting resources from our own governments into the investment case to reach the levels that are expected will be there in the next 2-3 years. It is a tall order. We've had the Abuja Declaration from my part of the world where 15% of the national budgets are supposed to go into health and finance HIV and other health initiatives, and that has not happened, and we keep oscillating between and less than 15%, except for very few countries in that region. So it definitely is going to take a process, but I think the issue is even a journey of 1,000 miles, starts with one step. So that step has been taken, and the efforts to put together the case, the investment case, and to actually have a dialogue where different players in the country and stakeholders are buying into this investment case and looking at what are the opportunities that we can tap into. For example, how much have we tapped into the private sector, and how much more could we tap into that? Amazingly, it's still from the communities. There's an initiative in one of the communities where the communities have gone out and worked out from their own, nobody's forcing them, but from their own initiative, they've seen that they need a community health insurance scheme at one of the TASO centers in a remote district, TASO Rukunjiri. A community has gone out there and said, you know what, with what we see with the health system, with what we see that is available to us, if we added this, so all those initiatives need to be galvanized, but it will indeed take a process, but the steps have the necessary steps have been taken, and the dialogue and the efforts towards making more investments has started, and I think it is the right direction if we are to look at the scale up We need more resources, and we need to tap them from wherever we can, and to get everybody that can play their part to play their part, right from the individuals, the communities, and then the various stakeholders, government, and also the private sector. And the people that have been giving us a helping hand, I think it's important that that helping hand is not taken away.
I want to add, and I'll be a bit more forceful here. You know, I find it disturbing, for trying to be polite there, that back in the day when we mounted globally a compassionate response to address mortality from HIV and AIDS, everybody ran to the podium to make a commitment for universal access. And we were going to help, and we were going to finance it, and we were going to do it. And year after year at the United Nations General Assembly, the commitments were verified, confirmed, and everything else. And when the moment came that we realized that universal access was the key to actually ending the epidemic, all of a sudden, people were running under the carpets, and the same voices that were going to fund universal access got totally distracted with the financial crisis and everything else. You know, that's where I think we're missing the outcry of the community, making the political leadership accountable for commitments that have been made long ago, have not been fully delivered, and we're still waiting to hear what is going to happen. And because I don't like to point fingers to others, I'll point fingers to my own federal government, who is a laggard when it comes to the contribution to the Global Fund and to the AIDS response. And I would like to see outrage in my own colleagues across the country, asking the federal government to match on a per capita basis, on a GDP adjusted basis, or whatever basis you want, the contributions that the Americans have made. And it could be the Americans, it could be the UK, it could be the Dutch. I mean, there are a number of people way ahead of us when it comes to this contribution, so that then we can turn to the rest of the G8 and the G20 and say, we expect that we all are going to match those contributions. There is no reason why, at the time where we have the opportunity to turn this around, we're saying, hey, Caribbean, bye, and Africa, I'm out of the game. It just doesn't make sense. This is a solution that at the end of the day works for us all, and the only way we can fix HIV and AIDS is if we do it globally. And yet I don't sense that our public is engaged and outraged about the fact that we made the promise, we walked away, and we're failing to deliver on what actually was a miracle of a promise.
Good point, passionately made. Yes.
After that passion, I don't know how I can measure up to that, but perhaps I can bring a little bit of calm into this. I just want to be clear that we are not saying that everything must come from outside. We, each member states and regions, have to take some measure of responsibility. And therefore, even as I speak, in Grenada, we are going through an arrangement with IMF, which is going to see us rationalizing how we spend our money, prioritizing, and doing what is most important for us, in which health is important, of course, the issue of HIV and AIDS. But coming on the heels of the last speaker, this issue of global solidarity is very critical and important to global health. Only a few days ago, I was listening to the news, and the issue of the recurrence of incidences of measles in the United States was in the news. And while we have in the Caribbean maintained an excellent level of immunization in the high 90s, and I don't recall having heard about measles for a long time in Grenada, but immediately hearing that there's an upsurge of measles in the United States, I am asking myself, how do we prepare ourselves in Grenada for this? Because given the globalization and the ease of travel, what happens in another region, especially when it's infectious, happens to us. And therefore, if the powers that be, our donors, just turn our backs, we might find that whatever negative impact that has on us will eventually impact on them and on the world. And I wanted to highlight that we have a responsibility, and we do not take it lightly. We are doing what we can. But given our numbers and economies of scales, we need. And therefore, this solidarity, we practice that solidarity in country, whereby we're now, as the sister said, we're looking at a national health insurance, whereby we do not wait until the person arrives at the point of delivery of healthcare to demand money, but we say you must contribute when you can. But of course, there are persons who cannot contribute, and so we're saying those who can must be for those who cannot. And likewise, globally, this is a policy that has to be looked at by the United Nations or whoever has to look at it, because what hurts one eventually will hurt all.
Do you have any thoughts about that, Minister Lake?
Well, Julio's trying to reel me into a political debate here, I think. But I'm not going to fall for that too hard. But I will say this, that it's true that people start to become desensitized when there's no burning platform, when you don't see, we talked about the mortality and I mean, all of you that are here today, I want you, before you leave the building, to go up to the 3rd floor, and you go up the escalator, and you go around the back, you turn left, and on the wall you'll see a Peter of Dr. Peter Jepson Young, who's a young physician here in Vancouver who contracted HIV and AIDS and documented through the Dr. Peter Diaries his journey to death with AIDS. And as important as 1996 was to Vancouver and to the progress that we've made on AIDS, from 1990 to 1992, the Dr. Peter Diaries came into our homes every night, and people saw what it was like to have AIDS, and with no apparent hope of a cure or prevention. And there was this willingness to get on board and put all the resources necessary to do something about it. And I think that's probably part of the genesis of why British Columbia has been so galvanized around this particular challenge. But for the other parts of the country, and in Ottawa particularly, you know, there was other things to worry about once the initial emergency faded. And much like measles, you know, I had measles as a kid, and once, you know, the array of vaccination programs were available and we got things like measles and mumps contained, people just became, you know, desensitized to it, didn't think it was a problem anymore, and now we have 300 cases of measles here in British Columbia. I mean, it's remarkable that we have that, and that's what happens when we do lose that initiative, that focus on the problem. It's a natural human trait, I think, and that is why we need to look at these types of programs that are successful in places like British Columbia and France and Brazil, and then put the resources through global organizations. And yes, our country should be contributing equally to that, so that that success can be repeated in other countries, so that we don't take our eye off the ball and allow those backward steps that we heard about earlier.
So then, Minister Lake, are you saying that the way that this province developed the political will to make this commitment years ago was by responding to what the public was saying, because the public was outraged?
Absolutely. We talked about, you know, the community activism, and the community here was activated very sharply by the Dr. Peter series. And, you know, I mean, that happened in other communities, and in Hollywood there were movies, and, you know, we were all you know, everyone that was around in the late 80s, early 90s remembers that feeling of despair and how do we tackle this problem and where is it going? It was remarkable, and the achievements that were made in a short period of time were also remarkable. But it took that uprising in the community through awareness, like the Dr. Peter series, to activate and galvanize the community.
Right, it was a very scary time, actually. Well, so speaking of the rest of Canada, I mean, here in British Columbia, the death rate has been dropping dramatically for the last while, and yet in other parts of Canada, it's still rising. And you're saying, Dr. Montana, that the Canadian government, the national government, hasn't embraced this same program. Why? I hate to hand you this soapbox, but we want to get to the bottom of it.
I guess because I haven't made enough noise in the rest of the country. No, just kidding. I think what happens is that it's a matter of priorities, and for the federal government, this is not a priority.
But why didn't they have the same pressure?
Well,
that
because these are not their voter base, and they don't feel that this touches them, and that's a very unfortunate situation. We have written to the federal government every year since 2006, and to the Ministry of Health, and the answer we get back is the same: is no, thank you, see you tomorrow. And it is unfortunate because the two worst epidemics in this country today are in Saskatchewan and in Manitoba. In Saskatchewan, 70% of the new infections are in First Nations individuals, and in Manitoba, 40% are in First Nations individuals, which is exactly within the jurisdiction of the federal government. And we yet have not been able to motivate them to do the right thing. As I said, it's a matter of political priorities. And so in the absence of a wider concern on the part of their constituency that this is not acceptable, then the political will to move federally is simply not going to be there. Now, the good news is that we have had conversations, very fruitful conversations, with colleagues across the country, and the separate programs are actually looking at this very much with a lot of enthusiasm and very seriously as of now. But it's taken a long time, and it shouldn't be like that.
Well, I guess that must be true in every country. If there isn't, for example, in Greece, if the public isn't demanding action, then it's harder to develop that political will.
I think Mark, in his video speech, gave a very critical point. We must no longer do averages, because this would hide what was happening in the First Nation. And this is almost like a genocide. Okay, it's not exactly, but but if you compare to any other group, or indeed the pictures that Dr. Lourdes showed, in Uganda at this moment, being gay equals to a huge increase risk of morbidity and mortality. And you wouldn't get prevention, you wouldn't get testing, and you wouldn't get access to treatment for a number of reasons. So I think that we have to bring out all these groups that are not receiving equitable access to prevention, treatment and care. And I think this would eventually create an outrage, even though it goes back to the problem that the groups which are most at risk are indeed groups for which sometimes politicians do not need to worry that much, apparently. And here is this difficulty that we face. In Europe right now, it was mentioned, the migrants are having very difficult times to access treatment, and particularly those with irregular documents. And the same is true in Greece, for example. So there will be pockets of groups which will be left out all the time, unless we do something about it, of course.
Right. Dr. Modeste Kerwin, and what about in Grenada? Is there a strong desire, a push by the population to make the government pay for this act?
No, actually, I cannot say. There is a push, but I can't say that it is strong. But what I do know what has happened from the time WHO set the target for us, that stimulated some action, not just in Grenada, but within the CARICOM region. And this has really catalyzed us into thinking how we can expand treatment for a number of persons. In that regard, and even before the target was set, I believe we silently set ourselves a target to prevent vertical transmission. And we have successfully done that for the past 3-4 years. Every pregnant woman is tested for AIDS routinely, just like you do the other blood works. It is a routine test. Of course, they have the right to refuse, but with proper counseling, we have found that generally everybody agrees to it, especially when they know that we have the treatment that could prevent the mother-to-child transmission. So this has worked excellently for us. But with this new target that WHO has put in and the regional discussions, this has really stimulated further discussions. And so while we do not have people dying and the sort of cachectic look and the kind of sadness, we are now looking at quality of life and universal access for everyone. So as the learned scientists and researchers look more at targets, we have a target set for us. We will pursue that, but we know that that is not the ultimate game. And as the time ends for that target, we will be looking at others. So perhaps it is not just the community outreach, which I'm not saying that is not very important, but I also want to add that in addition to that, setting targets, and it could be regional or global targets, it does help us to stimulate action.
Okay, Dr. Navarro, I wanted to ask you about the stigma that's associated with HIV and HIV risk groups. How much impact does that have at the community level of them getting the care they need?
Well, it is documented that stigma and discrimination really affects access to treatment. And there have been efforts for the last 30 years to work on ensuring that stigma, the environment is free of stigma and discrimination. And there has been an ongoing process. And until recently, when we have had the proclamation as it has been made, and it's still early days. And what I would say is that there definitely is a feeling that people are wondering, do I go to get care? And there is ongoing dialogue in terms of open spaces where people are discussing these issues. The days are still early, as I have said, in terms of the act has been put in place, but there's got to be guidelines that go into that, and there is discussion, and the safe place that we are focusing on for the immediate is the public health approach to care and ensuring that services are there, and people who are offering services and people who are coming for the services continue coming for the services. And there is a dialogue with Ministry of Health and the Uganda AIDS Commission to see what does this translate into in terms of the actions and what we know about stigma and discrimination and its impact on how people access treatment and services. There are various dialogues that are happening within the advocacy and rights approach with AIDS development partners, with the communities, and with the service provision to ensure that there is an ongoing process to build on what has already been done. The Ministry of Health, too, is taking lead on seeing how can we, within the context of what the legal environment now is in the country. I would say that it has to be a multi-pronged approach. And the reality is that that's the context that we live in. And for us as service providers is to see what's the best we can do in the meantime, even as the processes that have to happen in the longer term happen. I would say that it is important from either way to make sure that at the end of the day, within the space that we have, as much as possible, services continue, and that dialogue, where the dialogue is already happening, is not polarized and is not stopped. So as we are doing whatever we are doing, we are looking at what's the best way possible and forward in terms of taking forward what we have had as gains in the past, and to ensure that people get the services as their human right, even within the context of what we have. Because I think the best is to look at the situation, the reality on the ground, and to do your best within that circumstance. And even as people come to help, I think it's important to understand the context, to listen and see that whatever efforts are being made are not efforts that will curtail on the dialogue that is happening, but are efforts that will take us forward and move us forward and not cause even more polarization, which at the end of the day will be even more detrimental. In Africa, we have a proverb that when the elephants fight, it's the grass that suffers. So it is important that the powers that make some of these decisions are aware that at the end of the day, whatever approach is used will minimize and mitigate against even further damage. So I think that's the best I can say in terms of putting this, and say that it's still early days. We haven't had reports that people were stopped, people were put into prison. Like I've heard it mentioned, UNAIDS has come and helped in Nigeria. But it's important to protect those spaces and ensure that the dialogue happens and continues to happen, and that the services, as they have been offered and put forward, continue to be offered in the various places where they are, and as government then sees is the best way forward to ensure that services continue to be offered.
Okay, Nikos, how much, in your experience, what role has stigma played? How much impact has it had on people not getting the treatment they need?
Well, it obviously creates this vicious circle of people not receiving prevention information, not being afraid to test, not recognizing that their community is at risk. So it's just a vicious circle that keeps you, and that is when stigma and discrimination is not also at the level of state homophobia or what we have in Russia with the situation for drug users. So I think in those cases you really have almost criminal responsibility at the level of the state. The fact that you cannot have access to health programs which you have outside the prison, inside the prison, access to needles, substitution treatment. So I think all of these, the stigma and discrimination is actually translated into things you do not have access to. And it leads up to not having access to treatment.
Okay, well, how do we ensure that there is access to HIV treatment? Anyone like to take that? How do we ensure access?
Well, maybe I'll take a stab at that. Just when Julio was talking about, Manitoba, Saskatchewan, and the Aboriginal population, just thinking about the marginalized populations in general, the average person doesn't come into contact with marginalized populations, and so it's not something they think about every day. So it's up to policymakers to understand the problem and direct the solutions to the problem. And in Canada, it's complicated. It would be, it's, I think, a bit simplistic to say that, there should be one program across Canada, because we really are a series of little jurisdictions that, when it comes to healthcare particularly. So we all have responsibilities, and the federal government doesn't want to get into our space for obvious reasons, because it comes with a price tag, and same way we wouldn't want to get into their space in terms of paying for the military or things we consider a federal responsibility. But when you're looking at First Nations off reserve in places like Saskatchewan, that's the provincial government's responsibility. I mean, they are community members like anybody else, and we have to understand the problem and go in and deal with it through community-based organizations. And there are many that are willing to do that. And actually, tomorrow I'm off to Toronto to talk to my federal counterparts. So we'll be having that discussion, and we'll be adding that to the agenda in our future provincial ministers meeting in the fall. So I think rather than sort of worry about what Ottawa is doing, I think we need to ensure that each of the provinces are doing and learning from what we've done here in British Columbia. And I know you've had some productive talks with those provinces, so we need, people like me need to back you up and carry that message forward. But we really do need to target the solution where it's needed. And in Canada, I think it's relatively easy to see where those hotspots are. We just need the political will to go in and do something about it.
And Dr. Montana, you've had a lot of experience, sorry, in reaching those hard-to-reach groups.
Yeah, no, I just wanted to make a couple of points. I agree with everything that the minister said. How could I not? But I wanted to get down to a couple of technicalities that I think are very important. I strongly believe that the reason why we have been more successful than other jurisdictions across Canada is two or threefold. The first one is that we have truly free services in British Columbia. There is no co-payment, non-deductible. And when we are asking people to consider to engage on antiretroviral therapy, for example, or testing, if there is any discouragement, financial discouragement, people who have to make difficult decisions because, I have only this much money, I need to feed my children, I have to look after my shelter or whatever other priorities they may have, this becomes an impossibility. So that's number one. And the number two important issue is because we had the worst epidemic in the country back in the day, we developed a focus. And so if the infected population or the population at risk didn't come to us, we went to them. And so my simplistic lesson is that if this is going to work, it has to be free, it has to be readily available, we have to get rid of the structural barriers, and we need to bring the services to the people. Now, for that, we're going to have to adapt that to the geographic, political, socio-demographic context, but those are non-negotiables. If we don't have that, this is not going to work.
And Dr. Lourdes.
This is the crucial question, no? You secure access. There are some new demands to all of us working with AIDS, and protection is key. There is no way to guarantee access or to influence to access today if protection is not provided. As Minister Terry said, and this is primarily a responsibility of institutions, government included. On the treatment side, access to treatment, for instance, I think there is no way to work with drugs without putting one more D. Is access to drugs and dignity as well. There is, for anyone that want to work on access to treatment, access to service today, must work also to assure that dignity of people is protected. If not, you'll be talking to yourself. There is no way for science only. There is no one single via today that will work for people. And that's where protection comes together with everything that we have done during these 30 years. But that's not sufficient if we don't do that. To assure protection and to assure that dignity comes together with drugs, we need to go through communities. There is no way to do that relying only on governments. Even because we are basically dealing with a challenge in terms of protection of minorities. And one of the major risks when we operate in this arena is that minorities are taken over by political opportunism. And that we are seeing country after country today, where because majority may think in a different way, politicians take on that in an opportunistic way for votes, for short-term gains. But we have learned in history that play with minorities is extremely dangerous. Because first of all, does not stop in one minority only. It's an illusion to think that this challenge will stop in LGBT. Other groups will come. You never stop. That's what we learn from history. It's dangerous in terms of the future, but it's also dangerous in terms of the stability of the society as is today. You don't submit to vote rights of minorities, because of course they will lose. But human rights, they are inherent to everybody. It's not an issue to be put to vote. It's not an issue to be put to the political debate. It's not a choice for a government from a parliamentarian. These are human rights. And that's where communities play a fundamental role. I fully agree that there is no solution to this, to the wave of discrimination that we are seeing today from Russia to Uganda, to Nigeria, to Ethiopia, to Kenya. There is no solution on that without the communities in each one of these countries to taking over the response. The solution is there. There is no question. And that's where I think investment should go. It would be an illusion as well to think that the solution for Africa is in Europe or in the US, in contrary of that. The solution for Africa is inside Africa. And I really trust that the forces are there to play and to turn the tide one more time, as we did manage to turn the tide before. We need to turn now a different tide, but that as strong as HIV or even more. You know, I don't have a problem with HIV today. Huh? HIV we know how to beat. What's taking us over is the tide of discrimination, is the tide of stigma, and this is a big one. And this is where, that's why access is so much on risk today, to drugs, to treatment, to prevention, to any goods that we may count with today to move us to the end. This is the crucial discussion. That's what you define where we will be in the future in terms of beating AIDS or living with it for much longer.
Okay, thank you very much. And I think that wraps up our panel discussion. It's been really fascinating. It's an interesting time in the history of fighting this disease, and I'm sure it'll be a wonderful conference going forward. Thank you very much for taking the time, to our panelists, and to all of you for joining us for this panel discussion. Thanks.